Good evening, everybody, and thank you for joining this webinar. My name is Mark Collier, and I'm a tissue viability nurse consultant and associate lecturer in tissue viability in the UK. I'm also chairman of the Leg Ulcer Forum of the UK and a former council member of the European Wound Management Association. I'll be the moderator for this webinar, and we have two very good speakers who I will introduce shortly. The webinar is held in connection with the EWMA Compression Therapy Programme, aiming to investigate the use of compression therapy in venous leg ulceration and promote optimal use of compression therapy across the relevant healthcare setting. This is the first webinar in a series that's been planned in connection with this programme, so watch this space. The webinar will be recorded, so you will also be able to watch the webinar on demand. The recording will be available on the EWMA website within a few days after today. You will, of course, have the possibility to request a certificate of attendance for both the live participation in the webinar and also via the demand version. The two speakers will make a joint presentation this evening with a duration of approximately 35 minutes. To avoid shifts in screen sharing, the slides will be managed by the organizer, who we're very grateful for is supporting us in the background. The speakers will therefore mark slide changes by raising their pens. Thank you very much, speakers, just in case you wonder what they're doing. That's the cue to Julie. At the end of the webinar, there will be hopefully time for questions for you, approximately 10 to 15 minutes. But if we need to, we can overrun slightly if there are more questions than we've anticipated. Please type your questions in the questions box in the control panel whenever you have one, and include the country you are based in. The speakers will then answer as many questions as possible. I will be verbalizing the questions to them so everybody can hear the question that's being asked. Finally, we would like to thank all those who have asked questions in connection with this when you registered. We've looked at these already and they've identified some themes that, again, we'll try and integrate into the presentation, but also pick up on during that question time. So just before we start, it's very important that we do thank the sponsors of the EWMA Compression Therapy Programme, who are Hartman, Jobst and Ergo, for their support, without whom this webinar wouldn't be happening. These companies, just to reassure you, however, didn't have any input or influence on the content of the seminar that you'll hear tonight. So, at long last, I'm finally pleased to welcome the speakers for today's webinar. Our first speaker will be Professor Christine Moffatt, who is based or working at Nottingham, Trent University and Nottingham University Hospitals, amongst a number of other things that she's got on at the moment. And she'll be followed by Alison Hopkins, who I'm sure many of you know is CEO of Accelerate CIC, Wound and Lymphedema Care Centres in the UK. So without further ado, I'd like to hand over to our first speaker, Christine Moffatt. Over to you, Chris.
Thank you, Mark, very much. Good evening, everybody. It's lovely to be with you. Lovely also to share with two lovely friends, Mark and Alison, who I've known for many years, and to be able to share something we're really passionate about, which is compression and the transformational nature that compression has on our patients. And we really hope you're going to enjoy this. We hope we're going to dispel some of the myths that exist and stop people from using compression, and to give you, of course, this is a massive subject, so we can't, of course, deal with everything, but we hope to give you some real impetus to reignite, if you're feeling that you're not so engaged in compression, to really believe in compression as being so incredibly important. So the first thing I wanted to talk about was the fact that compression is transformational. It's one of the few therapies that I think you can look at the outcomes and see that they completely change the outcomes for patients. So they change healing rates. They increase the healing rates at 12 and 6 months, threefold, fourfold. They change people's lives. They improve their quality of life. They fundamentally change the lives of people. And compression, we're talking in this webinar particularly about venous ulcers, but I wanted to say, and Alison and I agreed that we wanted to convince you of the importance of compression for so many other conditions. So compression is not just for venous ulcers. It's there in its role of prevention of deep vein thrombosis, and it's there when you've had a thrombosis to help prevent the awful effects of post-thrombotic syndrome. And often the patients who go on to have leg ulcers have simply not had their thrombosis managed long term. So they have an acute episode of thrombosis, and then it's just left to develop the skin changes that we see in post-thrombotic syndrome. It's there to help people with varicose veins, and although the evidence base about symptom control in varicose veins is perhaps a little bit weak, nevertheless, anecdotally, we see people talking about the control of the heaviness, the aching, the edema at the end of the day that we see in varicose veins. And it's absolutely fundamental as the single most important treatment in venous ulceration. Venous ulcers will not get better because we put on expensive dressings or we tell people to go for a walk. They are all very important, but actually if we do not address the underlying reason why people get venous ulcers, they're simply not going to get better without compression therapy. It's absolutely a fundamental part of lymphedema management, and although people with lymphedema often have what we call complex decongestive therapy, which involves not just compression but a special form of massage, manual lymphatic drainage, we need other things such as skincare. Nevertheless, in lymphedema also, compression is vital. We hope, Alison and I, to convince you that compression is also really important in the management of mixed etiology ulcers. And we're increasingly seeing people with many different comorbidities, including those with concurrent peripheral arterial disease, with diabetes, who also can have compression therapy very, very effectively. But the other thing is that compression is also incredibly important in its management of edema. And edema is called part of wounds of all sorts. For instance, I wonder if any of you realize that actually edema is one of the reasons why pressure ulcers do not heal. And compression for leg wounds is absolutely vital to reduce edema. And pre-tibial lacerations, the patient who goes off to the supermarket and bangs their leg, shears off the skin off the front of their leg, they don't improve, they end up having an ulcer. Why? Because actually you're not using compression. So compression is very important for leg wounds, and I know Alison is going to reinforce this. So firstly, let's look at the size of the problem. Well, first thing to say is that the epidemiology studies are largely outdated. Alison and I have both been trying to improve the science behind what we know and to give us some up-to-date information. But often still we talk about studies that were completed in the 1980s, 1990s, and of course the populations have changed. But I can promise you it's not going away. It's a huge problem in all populations, both the West and in countries like Japan as well, where it was considered to be a rare problem. It's a growing problem. And I think we are very aware that patients are changing. They're becoming more medically complex. They've got more comorbidities, age is increasing, and there are many factors that mean when you're treating a patient, you've got other factors to think about in relation to wound healing. So we're dealing with more elderly, more obese, more immobile populations, especially in Europe. And people are found in many parts of the healthcare system. And one of the challenges we have is who owns the leg ulcer patient population, the wound population. This is perhaps a really big challenge for us. And people always talk about the challenge of getting people to wear compression. I'd like to say that adherence is not static, but actually many of the times people can be encouraged to wear compression if we get the compression right. But we hear this very much as a factor that may contribute to delayed healing. But often it's back to the issue of the choices that clinicians are making as well. So we talked about improving the science. This is a paper that I published last year in Lymphatic Research and Biology. And we did a study in 3 populations, 2 parts of Nottingham and Leicester. And we had a chance to clinically assess every single patient who was receiving community nursing care in 3 cities. So these were 3 urban services, and we assessed prospectively over 4 weeks all the patients, irrespective of whether they had a leg ulcer or a wound at all. So the 2,500 people were assessed, and we were really shocked because nearly 57% had got chronic edema. It was in one population, it was as high as 68%, but more worryingly, 73.6% had got a concurrent leg ulcer. They were an elderly population, and in that population, about a quarter were reported to have cellulitis. Now, this is something that there's an issue about diagnosis, but many of these people were not receiving compression appropriately. And we did some independent risk factor analysis, and we found that where the patient lived, their age, older age patients, ethnicity, if you were white Caucasian, you were much more likely to have a leg ulcer. Having obesity, heart failure, and wounds were all independently associated with having chronic edema and having a leg ulcer. So this is a huge unrecognised primary healthcare problem of today, and it's, I'm sure, the same in many different countries of the world. So let's first centre ourselves. I've been around too many decades, and I want to give you this picture. This was a picture taken in 1985. And I want to remind us that actually this is the kind of world before we have compression therapy. And it's easy to think, well, perhaps these patients don't exist today. Actually, they do. And in many parts of the world, compression is still not being used. And this is a patient who'd been 2 years in hospital facing bilateral amputation. And compression was what this patient needed, and it was denied them because it was an era when compression was still in its infancy. So let's think about the fact of venous ulceration. Now, this slide is a busy slide, and I don't want to go into some of the central part of this algorithm, but I want to remind us that people end up with having a venous ulcer due to many different routes. So a proportion of are going to have had a thrombosis that's damaged their deep veins. Some of them will have had varicose veins. Some of them are primary varicose veins, so they were born with varicose veins, and about a third of the population have varicose veins that they're born with or develop over time. And some will have varicose veins as a consequence of having their thrombosis. But increasingly, we're seeing people who are immobile. So they just have no calf pump function. They're sitting with their legs in an immobile situation. And this combination of factors leads to having ulceration. And the common pathway to having a venous ulcer is the development of venous hypertension that causes the pressure to rise in the capillary bed. And this leads to all sorts of secondary changes. It leads to white cell entrapment. It leads to development of cytokines that damage and cause more tissue problems. And all of these contribute as well, not just to damage of the venous system, but also to damage in the lymphatic system. And these lead on to the development of ulceration. And we know from the evidence that the higher the hypertension and the more prolonged that hypertension, the more the likelihood of somebody developing ulceration long term. And sadly, once you've had one episode of ulceration, you're more likely to have more episodes. So this is a salutary reminder of the pathway. So we have lots of myths, we have fact or fiction. So we have what's a simple or a complex ulcer. I think Alison and I could debate this for many, many hours. But actually, some of the things we know is that the original risk factors, I've done work on this, Margolis and others have shown that ulcer size, a large ulcer and an ulcer duration are important factors. But we know there are other factors. So, for instance, the mobility state of someone, if they end up being completely immobile, if they have a fixed ankle joint, then that has a dramatic effect on the power of healing because it has an effect on venous return. Some studies have suggested things like the underlying venous pathology, popliteal reflux are also important. Other studies dispute this. But also it's not just what I call the clinical pathophysiological issues, it's the social and the psychological factors that are also very important. So things like depression, levels of anxiety, levels of pain, sleep disorder may also be directly attributable to non-healing. And of course, things like the size and the duration of the ulcer may simply be an indication that compression is not being used. So the patient deteriorates, the ulcer becomes of long time duration simply because they're not having compression early enough. And we know that actually the longer we leave wounds, the more chance that we actually have for things like biofilms to develop. And we know that with repeat episodes of ulceration, that over time they may become more difficult to heal. So all of the patients in this slide are indications of people who need compression. And I simply want to say to you that compression is an art and a science. So we need to understand the science, but we actually need to understand that some of the pictures here are simply that people don't know how to apply compression appropriately. So if we take the picture on the right-hand side, this is one of my patients. She's from India. So she's got a hugely disproportionate limb shape. She's had an ulcer, a venous ulcer, but she's also had a big abscess occurring in the thigh. So actually knowing the science is all very well, but actually you've got to know the skill of how to deal with a disproportionate limb in a situation like this. And the huge white scar that you've seen is not an ulcer, it's actually scar tissue in someone from a black population where their scar tissue has formed as a white scar. If you look at the picture at the bottom, the foot picture, we see these awful toe problems occurring simply because people don't know how to use compression appropriately. And so people end up having the kind of lymphatic changes you see, even though they're actually an underlying venous problem. And the kind of pictures at the top, the forefoot edema, occurs because we've been taught the wrong way to apply compression. If you don't apply compression to the foot, you end up having problems with forefoot edema occurring. So these are examples of the kinds of issues. These people need compression. They've all got an underlying venous problem, and we need to use compression appropriately.
So thank you very much, Chris. That's a fantastic start to our discussion around lower limb wounds and leg ulcers. And so my section is really about the impact of words, the words we use around leg ulceration. And so I'm introducing some of the key highlights from the EWMA compression project and some of the audit work that we've done. And we would say that words are important, and I'll explain why. So we have various guidelines and they all talk about venous leg ulcers. And I suppose the thing that we'd like us to all to think about is the impact of the leg on having a wound. If you have a laceration on the arm, it doesn't tend to create a massive problem of non-healing, but it does on the leg. And why is that? Well, go back and watch this later and listen again to Chris on the issues around venous hypertension. But a leg is different to an arm, and this is really, really critical to the way we see wounds and the prevalence of wounds within our community. So in prevalence audits, we like to split all these things up. We'll have pressure ulcers, surgical wounds, acute wounds, chronic wounds. And each study will have their separate criteria. So when you're looking at studies, then do look for the understanding around the criteria that puts someone into an acute wound or a chronic wound. And there is a hidden issue of lower limb wounds. So in the European study that we're doing, there are 6 community sites in the UK, and so far we've audited 2,700 patients from a population, a community nursing population of around 1.7 million residents. And so we've got a very simple online tool that looks at the details around these patients. And what we're really looking at is the burden of lower limb wounds within a population, as well as the provision of quality interventions. And what does that impact on the nursing burden, on activity, and also admission avoidance and so on. So these are the things that we've been looking at. So I'm just going to present some very high level, sort of hot off the press reports. So here we have a worst wound example. So when someone's filling in the audit form, people would decide whether they're a leg ulcer or a surgical wound and so on. And the interesting thing is around the way we categorize skin tears or lacerations, as Chris referred to, the pretibial lacerations. And if I can just draw your attention to the fact that leg ulceration as a group was about 25% of the caseloads for across these sites. But the lower limb wound was present in 46% of the population. Now that's a very significant difference. And this is about the way we perceive the wound that we're seeing in front of us. Is it a leg ulcer, or is it a skin tear or a surgical wound on the lower leg that's not healing? And here you have a couple of pictures here about the issue of that laceration with some lower limb edema. It's already been sutured. You know as well as I do that that presentation doesn't bode well, and that this person really needs to get into compression before that simple laceration on holiday becomes a non-healing ulceration. So we've got a hidden group, and it's this hidden group that's our sort of the gains for our population and a lost opportunity. So here we also have the worst wound location, and this is significant and again shows that the predominant group are those that have a wound in the lower leg and ankle malleolar region. You can see this quite clearly, and it sort of jumps out at you when you're doing the audit results. Sorry, pen. So what's interesting about this is that when you look at the way wounds are classified, you suddenly realize that actually if you've been classified as a leg ulcer, then your access to certain treatments is very different than if you were being classified as a skin tear or a lower limb laceration or a burn or a non-healing surgical wound on the lower leg. So you can see here the impact of this sort of subtle change in words. So if you're classified as a leg ulcer, you might say you've got a quarter of the wound population are leg ulcers. However, 46% are in the region of the lower limb. Compression usage, if it's a leg ulcer, is 57%. And actually, there's something, I have to say, there's something slightly wrong with this slide because it isn't 65%. I do apologize. I have to look at that. The burden of activity is an important one, though, is that if you're using compression therapy on a lower leg wound, the average is about 1.4 activity a week. But if you're not using compression on a lower limb wound, then the activity is increased by 21% to 1.7. And that's a very simple sort of evaluation of the impact of compression therapy on your burden of care. And the important thing is as well, is that the compression usage across the audit also contained those that have been seen in a leg ulcer clinic. Well, we know that in the home it was actually quite a lot less, and across the sites it was around 39%. So access is also to treatment is also determined by someone's mobility, their ability to get to a leg ulcer clinic as opposed to the home. And of course, we know the population is different too, but these are sort of like little red flags that mean that someone's access to the right treatment is reduced. What we do know is if you are known to a tissue viability nurse, then the access to compression increases. So the effectiveness of treatment is quite interesting. So if you've been diagnosed with a lower limb wound, then you may have a diagnosis given to you of about 80%. So 20% of this group don't have a useful diagnosis from which to base the treatment. If you have a leg ulcer, then it reduces to 7. Access to ABPI, again, is reduced in the lower limb group. Access to compression is reduced in the lower limb group. And access to high compression, which is proper treatment, is also reduced. So what we know is that if you classify someone as a leg ulcer, then you're more likely, for whatever reason, is to get someone into treatment more effectively. So words do matter. So one thing that we're thinking about is if someone is doing the right thing in one group, how to extend doing the right thing to more than just those with a venous leg ulcer or those with a mixed leg ulcer. There are many others that would profit from having compression therapy. Those with a small laceration, not massive venous disease, but you get them in quick and they don't become a drain on resources by the end of the year. Those with vasculitic or sickle cell ulceration, they have wounds on the lower leg and they need to get into compression. So how do we break the cycle? By seeing everyone as some form of leg ulcer from the off, means that they're way more likely to have an intervention that's useful. So one other thing, and I was looking at the questions, and Christine talked about this as well, is the issue of patient compliance. We're always thinking that patients are the ones that are the problems. They're the ones that don't want the compression, and this is a major hindrance. When we looked at the number of people that didn't have compression, and that was 43% within the lower limb group, we asked why they didn't, and 44% of the reasons was because the clinician said it was not required. They were making the decision. This is not about the patient. And of that group, it was because they believed in their clinical judgment it wasn't required. And interesting enough, only 13% of the group was due to a patient request on non-compliance. So the interesting thing about this is that we have this big, if any focus group, we will see a big problem with patient compliance, that they don't like high compression. But I would definitely say that in our experience, the opposite is true. People know what's good for them if it's working. So we'll talk about that further down into the webinar.
So thank you, Alison. That's really useful and very insightful to see what's happening in terms of the UK and in terms of the work that EWMA is doing. So I wanted to just spend a few minutes thinking about the effect that fear has on compression. And why are we so afraid of compression? And I think this is very complex. I'd like to really have a chance to study how and why it's evolved in the way it is. But I wanted to start with some things that, in a sense, reminding us of the skill set that we need to have. I mean, I've talked about the art and science of compression. It's not just about being able to select the right product. It's about knowing what you do with it. So I always describe this picture on the left as my Friday afternoon picture, where I talk about poor technique. But I don't know whether the person applying the compression had their eyes closed. They obviously know they kind of applied compression around the gaiter region, around the ankle, mid-calf, and then they start to think about applying compression again. So this is about a skill set. This is about not having, because this person, the edema is simply by the application technique being wrong. I do recognise the picture in the middle, the gross shape distortion, is not something that Alice and I can do in depth with today. So forgive us, we can't deal with that. But this is about, we know the realities, because shape distortion does make it very difficult to stop slippage. And in a patient like this, a gross, morbidly obese patient of mine, where do you stop the compression? Well, we know with venous ulcers, it's the below-knee compression that's most important, because you're addressing gravitational, the effects of gravitation on the venous circulation. If you're dealing with a lymphedema patient, then the dilemmas are much different. You have to look at sometimes you have to look at deciding whether you use full leg compression. And these are, again, also influenced by the individual patient. If you take the picture on the right, this is a patient who's a nursing home patient. They've got an underlying venous problem, and the damage to the tibial crest is simply because actually nobody's recognised that actually this is a patient with a thin leg. The tibial crest is very exposed, and the person has just applied the compression without recognising that they've caused a grade 4 pressure ulcer. I mean, it's as simple as that. So it's about skill and about knowing your individual patient, being able to adapt your compression for individual patient. And I've said our pages are changing. I deal a lot with complex patients, and the obese patient population is an increasingly complex one. And I'm not suggesting the patient on the right-hand side is a real challenge for all of us. And I'm not suggesting that they're easy to deal with. But if we take the legs of this patient, actually this patient had a severe thrombosis. This patient on the leg on the right is actually at presentation, and it was an acute obstructive thrombosis. The patient by that afternoon had pulmonary emboli and needed to be thrombolized. And actually that patient did really well and is in compression and is being prevented from having long-term ulceration. So even in the complex patient population, we can address these issues. Well, I recognise that they're more complex. Now I want to talk a little bit about the issues of how the Doppler ultrasound recording of an APBI has emerged over time. And I have to hold my hands up to say that I passionately believe in the need for correct assessment and the role of Doppler. And I was one of the first people in the UK who fought for nurses having access to Doppler, because we need to recognise that leg ulcers can be caused by peripheral arterial disease. So actually, if you look at this picture on the left-hand side, this is somebody with critical ischemia. And 10% of people have a leg ulcer because their arterial circulation is so bad that it's causing ulceration. So we need to understand that we must pick those patients up. But we need to not just rely on whether we can do a Doppler ultrasound and record an APBI. If you can't palpate pedal pulses and your patient is telling you they've got rest pain, you need to be thinking about that whole patient. If they tell you they've had myocardial infarction, cardiovascular disease, then the alarm bells should be ringing that this somebody has underlying cardiovascular disease. So we need to pick these patients up. And that's not just the Doppler, it's about the whole of the patient. Because if you apply compression to these patients in the wrong case, you can, of course, cause massive damage. And of course, in a small proportion of patients, you'll actually cause death. So the story around why Doppler came is this understanding the whole leg ulcer population. And we need to know when to escalate. We need to know when to refer them on to vascular services. We need not to keep people in silos when we should be doing more, to refer them to the people who can do more. So we need to be able to recognise that compression in people with critical ischemia can cause a lot of damage. But it's a small proportion of people, a small proportion that we need to understand about. So why do we get pressure damage? Well, the first thing is we do it predominantly, pressure damages occur because of the way we are applying the bandage. So it's predominantly because we don't know how to apply a bandage. Peripheral arterial disease, critical ischemia, excess local pressure can cause damage, and we need to think about the patient with neuropathy. If you've got neuropathy, you don't know that the compression might be causing you a problem. So the picture at the bottom in the middle of this slide is pressure damage in someone who's got neuropathy. So they're not able to tell that bandage was causing a problem. And of course, there are systemic conditions, inflammatory conditions, where compression cannot be helpful. So, but that's back to our correct diagnosis, our correct assessment. It's about thinking about that whole patient, making sure they've had a correct medical diagnosis, they've had a review of their medications, and we have a clear picture of what's going on with that patient. And each of us have a duty of care. And if we do not know what's wrong with that patient, then we should escalate to somebody who can help us with that diagnosis, whether it's tissue viability or whether it's specialist services. That's our duty of care. So then we have many dilemmas, and I want to say that Alison and I can't deal with everything in this webinar. We have difficulties of terminology, whether we describe compression as elastic or inelastic. That's also a big hot issue. Stiffness, the ability of a bandage to be able to work in terms of generating high working pressures when somebody's exercising. We have issues such as the description of multi-layer systems. And all of this can be very confusing, but we do need to know that venous ulcers require high compression. They're just not going to get better with a minimal amount of compression. They need high compression. And one of the difficulties we have routinely is we're not able to know the dosage that we're applying. This is a real dilemma. But to get compression to work in venous ulcers, it's a combination of knowing the types of material you're using, how to use them appropriately for the right leg, and to recognise that it's a mixture of the materials, the patient characteristics, and within that, not just the clinical, but the psychosocial characteristics of a patient and the skills that you have. For instance, this picture here, it's a large leg. It's a large leg with a venous ulcer. You're going to need to know how to adapt compression for that. So the size of the leg matters. We talked about obese patients with large ankles and with large legs with a circumference at the ankle of over 25. We often cannot achieve a therapeutic level of compression with routinely applied bandages unless we know how to adapt. And we need to be able to do that. So large limbs are in danger, have not enough pressure, and very small, tiny limbs, such as the one I showed you with the tibial necrosis over the tibial crest, we're in danger of applying not enough, of applying pressure damage occurring. So the art and the science are important. So I want to just encourage you that new science is suggesting that compression is really safe even when you've got a degree of arterial disease. This is work done by Giovanna Moschi and Hugo Parch, and they took people with established arterial disease with an APBI reduced down to 0.4, and they treated them with an elastic system with an initial application pressure of 40, and they found there was no reduction in arterial flow. The venous pump was working better, the edema was being reduced, and that massaging effect was probably actually increasing local perfusion. And it's only when you get to people with really severe critical ischemia that you saw a reduction in arterial flow. So my messages are compression is safe, even in those with a degree of arterial disease, and that we cause harm by not treating the underlying condition, and actually we actually potentially reduce arterial inflow. And if we deny people compression, we reduce the chance of healing. That perpetuates a cycle of pain that they're in. We reduce their quality of life. And we actually increase the burden on the health services dramatically by not using compression effectively in these patient populations. And actually in the 1980s, early 1990s, I was showing that we could heal 78% of people within 3 months by just the use of compression. In simple in community clinics run by community nurses.
So what I'd like to do now is just to lead on. Hey,
just a couple of minutes.
Yes, so I've got to reduce this. So just to end on a couple of points, really. The National Wound Care Strategy has used a new phrase within the lower limb guidelines that says compression should be at least 40 millimeters of mercury pressure. This just recognises the fact that 40 is not the top of compression if you're using inelastic and you're looking at working and resting pressures. This is an important aspect of our work. So what we just need to think about is the fact that the standard limb is actually, who's standard? We need to look at the people that are non-standard in their height, their weight, their leg shape, and even their ulcer site. And this is where we may need to be more creative, because if you just put a standard compression on and it's not working, what are you going to do? Are you just going to leave them with that non-healing wound, or are you going to have to think about a plan B? So who are your non-healers? And the non-healers are often those that are very large or very tall. And so the standard is good for a standard person, but if they're non-standard and they have very long legs, then they need something different. So we do have a problem with standard care, and standardization is really great for a standard group of people, for the average. But just a couple of thoughts to end on is that we need to look at site in the first instance. If you can see on the wound on the left of the screen, you've got someone with great guttering showing great reduction in edema. But if the wound was at the ankle, you can see that the standard compression that is compressing from the ankle up would not actually deal with the edema at the ankle. The one on the right there is a sickle cell ulceration tucked in behind the malleolus. She had great compression for several years and it didn't do anything until we addressed the compression at the back of the malleolus with strapping or pads. And just to end on about what is standard compression in the UK, we think of compression as being the top is 40, anything over that is dangerous. Within the international consensus with the World Union of Wound Healing Societies, they describe it differently. And they talk about strong as being 40 to 60. And I have to say that this is also about the working pressure within the inelastic component. So I would just commend you to that reference if you want to know more about extra high compression. And just to finish on, within the EWMA audit, we were looking at the impact of men and looking at the fact that predominantly women have venous leg ulcers, but actually the non-healers, there's a growing group of men. Why is that? We don't know. Is it about their height and their size, or is it to do with the ulcer site? We don't know. But there's some things that we need to think about if the wound is not healing, to not just go, I've put compression on, it's working, or it's not working. We've got to deal with the issues in front of us and be creative with our solutions. So the observation is, Chris has talked about therapeutic dosage. We've got to think about the compression we're putting on. If it's not working, what are you going to do to make sure it works? It is an art and it isn't just a task. And the importance of review of that efficacy is very, very important. And just making sure that someone has a comfortable bandage isn't enough. It needs to be an effective bandage. And we need to look at the dosage and how we increase it and optimize the compression and the consistency of care for this group of people. I think we've got any questions? Sorry, I rattled through mine, I'm afraid.
No, that was great. Thank you very much, first of all, to both Christine and Alison. As always, very informative and very insightful. Lots of good information there, which I'm sure the viewers will find useful. Just to remind people that if you can answer, if you want to ask a question, sorry, if you want to ask a question, whoops, just having a problem with my computer here. I do apologize. If you want to ask a question, remember to use the questions box in the control panel. That's fantastic. We've had a couple in already, but just before we get to the questions, Christine and Alison, can you just comment on what strategies you might have used in the past to get clinicians to apply compression early in the pathway, and also in relation to the point that Christine made about when the ABPI is between 0.4 and 0.8. People tend to have this, I won't put it on below 0.8 thoughts. Can you either comment on that? Christine first, or Alison first? Then Alison.
Okay, a couple of things on that. One about the 0.4 to 0.8. What we have to understand is what is causing the non-healing. And if you've got a dripping leg and it's stripping the skin and causing terrible pain and excoriation, we've got to deal with that regardless of the Doppler result. And so if you've got a Doppler 0.5, then you can put on light compression and build up, and to assure you and the patient that all is well. And so we have to address the issue in front of us and not just go, our hands are tied, because my guidelines in my trust say I can't put any compression on below 0.8. What that means is harm, because it's stopping your creativity and it's stopping you addressing the issue, the clinical issue in front, which is a dripping leg that simply needs a squeeze because it's a leg and not an arm. And as long as we've assessed and we've put some rationale in front of us, it shouldn't stop us. We should see it as a therapeutic treatment like steroids or strong analgesia. We risk assess and you evaluate.
I think just to add to Alison's comment, for the wet leaking legs and they've got severe chronic edema, even a small degree of compression reduces capillary filtration, which immediately has an effect on the wet leakage. So even if you're not having a dramatic effect on venous return, you can still affect the capillary filtration rate, which stops the edema. So, and it doesn't have to be even a high dose for actually just to see that wet leakage. And I was interested in Alison's slides because you've got a very small proportion described as lymphedema and then quite a big box that describe wet leaking legs. So you've got people who are not recognizing that they've got chronic edema.
Yeah.
So I think that if I have a patient in front of me, I'm very clear that I want to give you a therapy. So I always say to them, you know, compression is a therapy. If you came in with a broken leg, I wouldn't send you out with a stick in plaster. You put your leg in plaster. And it's a therapy, and it has to be that. And we have to view it as a treatment effect. And it's no good giving an aspirin for pneumonia, is it? I mean, it's just not going to work. So we've got to not only educate clinicians, but for patients, and to understand you're giving a treatment. And if you give the wrong, you know, what's the point in giving something that's only half a dose? So I think we need to treat them immediately. No delay. If you've had a leg ulcer before anyway, you're always a leg ulcer patient. You do not have to wait for some magical time to start compression. You start it immediately. First assessment, first time the patient's seen you start it. Patient shouldn't go out of the room without starting compression.
So going back to your first question, Mark, we're excited in the UK with the National Wound Care Strategy because we're saying that you can put light compression on a type 3A or a class 1 hosiery from the off. And what this will do is stop a laceration simply turning into a gross leg ulcer that where everything cascades into a terrible situation. And so by doing that without an ABPI initially, we're saying that that's safe to do. And I think that I'm hoping that it would change our view on compression, that the fear factor around at least light compression is reduced. But of course, what's essential is that we do not stop there. And the next assessment, if the wound is not healed in 2 to 3 weeks, you've got to go into a full assessment with an ABPI and high compression. That's absolutely essential. But you might, in the doing, get rid of some really simple wounds, which is really exciting.
Excellent, that's great. Thank you both. And picking up that point about compression therapy, one of the questions that's come in is in relation to where is the best place to learn about compression therapy? Does it have to be a university? Any comments?
I have to be careful because my employers might be listening to me. I mean, from my view, you can never learn everything in a university. This is a practical, you have to learn it in practice. I mean, we can teach you the theory, that's fine, but this is a hands-on skill. You need to be able to feel, you need to be able to apply it in practice. You can do simulations, of course, and all of that, but actually, from my perspective, you can teach, even sort of teaching on volunteers is a very limited effect. The only way you can do this really is with patients, where you can really deal with the realities. Of course, I mean, there are leg models and many other things that we can use, but clinical practice is the learning place.
I would completely agree. And you have to see the fruits of your labor. You have to see what you did and the effect, you know, the cause and effect of what you've done, what worked, what didn't work, especially in misshapen legs, is absolutely essential. And alongside that, the being curious about what you're seeing and what isn't working, and also understanding the theory. And so there's some good people to read about compression theory, and I think there isn't enough understanding of compression theory, and so there's key authors, of course Christine, and I would say Hugo Parsh and Mosty. You know, if you read everything by those two, those three, you'd be great.
But I'm not great, so I don't think that's the case.
No.
We still have so many problems.
Well, we do, but we're being curious about trying to find solutions, aren't we?
Indeed, indeed.
I think that's the important thing. We're always trying to find the best way to do things, aren't we? So somebody here has asked, can we define what a multi-component bandage is?
Oh,
Well, a multi-component bandage is more than one layer. And I think we haven't got really time to talk about the difficulties of this. It is a difficult issue. But multi-component, the classification that the ICC developed many years ago was really about trying to dispel the myth that you could have a single layer bandage, because actually in reality you can't. But multi-layer components mean that the system is made up of a number of layers. And I mean, there are so many variations that you need to understand more about the types of materials you're using. And this is one of the difficulties we face, because actually when you start to use, for instance, cohesive materials, that changes the stiffness profile. When you're using combinations of layers, that changes the application. So these things are something that also more about the science of bandaging. But actually at the end of the day, you need to be able to use the system with your patient and be able to adapt the system, and to be able to use and to understand how that system has been developed, to look critically at whether there's the evidence around it, whether it's been tested, how it's been used in different populations. So whilst we've got art, we've also got to have science as well. We've got to try and improve on the way in which we're reporting and helping people to understand. And I think Alison and I would be the first to say that it's a very confusing world for compression.
and I would just add into that about multi-component. We don't know the answer. So there are going to be a group of people, however good your compression is within a community, you're going to have 10–20% of people with good stats that still don't heal at the end of a year. So who are they? What do they need that's different? And you know, the other day I was putting on multiple layers of cohesive short stretch, and then we put a wrap on top. Is that, you know, so because we know that we still weren't quite getting the dosage that was required. So in the UK we have a phrase, the proof of the pudding's in the eating. It's like, how good is the compression? What level is needed? Well, we don't know. Who have you got in front of you? If you've got a very skinny leg, you've got to be very cautious. If you've got a very tall man that's 6'4" and a large BMI, what is the upper limit? Chris?
And I think that it's really important to think of this as an interdisciplinary issue. I mean, this new evidence emerging about the importance of venous surgery, of correcting venous incompetence, not just on preventing recurrence, but on actually healing. So if we've got someone who's non-healing, have we escalated this? Are we sure that we have all of the diagnostic picture to offer the patient that best solution? Are we sure we haven't got an underlying autoimmune problem that might not be? Are we sure we haven't got a hemoglobin that's just the reason for non-healing? So we must not be isolationary. We've got to think of this as a team and not stay in a silo, and do our best if someone is not meeting where we think they should be, to escalate this up to someone else who might give greater insight. We just got to stop being singular in our attitude about this. And I know that's a challenge for many people because they don't necessarily have access to the services that we should have. But from my view, it's critical for achieving the best results we can.
Okay. Just with everybody's permission, we're going to overrun by another 5 minutes, if that's okay. Try and get some more questions in. So the next one is, if we put compression on, should we, whichever compression system it is, should we always recommend exercise at the same time? And if so, can we make some recommendations as to what type of exercise? Alison.
Of course, exercise is absolutely essential if people can, obviously. But there are some simple exercises people can do, and it is about the calf pump and getting some better ankle mobility. If you've got access to additional support, then getting the right footwear to enable someone to walk well with either a rocker or insoles, so their foot pump is working more, or these things are absolutely essential. And we also teach, there's two things that we do in Accelerate. One is we have a timed up and go, where we are looking at their measurement of walking in a certain little pattern, and we work on exercise with them to see if they can speed up their walking and reduce their falls risk, because that's another issue. And the other things we do is we teach people TheraBand exercises, and that's really good resistance exercise. And in fact, our lead in this area, Ina Farrelly, has just put a video on our website around TheraBand exercises. Absolutely essential. And I think in nursing, we think, oh yeah, they've got a little bit of a movement in their ankle and that's enough. It isn't. You've got to work at this like any other exercise program. You've got to work at it.
I mean, I'd like to support Alison completely in that. I mean, the importance of having compression on when you exercise on venous and lymphatic function, actually the wearing compression is so incredibly important. And even in your very immobile patients, the effect, I mean, the worst scenario for a venous ulcer patient is actually not the ulcer duration or size, it's having a fixed ankle. And the relative risk of healing with a fixed ankle drops by 90%, because and they drop largely because they are immobile, often when they're in pain as well, plus some of the fibrosclerotic changes that are occurring in the tissue means that over time their ankle becomes fixed. So even the most immobile patient, simple dorsiflexion rotation movements can be enough to stimulate both the carpum, and even the effect of putting the foot to the floor is enough to drain the veins of the foot. So really, really important to try and do that. And elevation, because as soon as you're able to elevate your feet above the level of your heart with a venous patient, you are reducing the effects of hypertension on their system. So actually going to bed and elevating, I don't want people to be immobile, but actually taking the effect of the venous hypertension is also very important.
Yes, just to add to that, we would often, when someone is very edematous or has got a major problem that we're trying to turn around, I would see going to bed as part of treatment. That going to bed for 2 hours in the afternoon or 2 hours after lunch and then early evening is not a lazy thing. It's a really important part of drainage and part of the treatment plan. So we would encourage people by having that as part of their treatment plan, rather than thinking they have to keep mobile and potter all day.
Okay, I think this webinar certainly illustrated the need for a lot more discussion about compression therapy, and also the importance of the EWMA compression program. But a final question, and with apologies to all the others that have written questions for us. Is there a role for compression therapy in pyoderma gangrenosum?
Oh, absolutely. Absolutely there is. It's on the leg, okay? And pyoderma, what a nasty, nasty condition. What I would say about pyoderma is it's absolutely crucial to get the medical management. You won't get anywhere without good medical management and reducing the inflammatory process, so getting the right medication and so on. But from a compression point of view, again, Chris, you may have different experience. I would say that a light elasticated bandage is a good first stop for enabling someone to tolerate compression where pain can be extreme. So, you've obviously got to work with someone around that. And then I often find, so that's like a type 3A bandage. And again, once confidence is built up, doing another 3A bandage on top of that seems to be a conforming way of just slowly increasing the compression. Then once pain is managed and medical management is clicking in, then a variety of compression works for me. But pyoderma, really nasty condition, but absolutely the task needs to be to get someone into some form of compression. As Chris said, it's a therapeutic intervention for the lower leg.
Yes, Chris.
Alison, I really support what you're saying. I think we're also very afraid of trying to manage pain in all of our leg ulcer patients. And whilst I'm the first one to know that pain drops dramatically in the venous ulcer patient when we put compression, actually we know it can peak in the few hours after applying compression. So we've got to just be confident and help people to understand that actually pain does drop off, but we've got to manage pain effectively. And all the evidence is if we leave pain unmanaged, it becomes a chronic neuropathic pain that's much more resistant to treatment. So we should not be afraid of actually offering appropriate pain relief to our patients and looking at the effect. It's, it's not just nociceptive, it's neuropathic pain. That these people need other kinds of medications to address this issue, and not be afraid of trying to combine those things. Because if you do not give someone symptom relief, how can you then expect them to manage treatments? I mean, that's just a reality that's too far for them to do.
And just a comment about very final about compression being, Chris said right at the beginning, it's transformational. It's a potent therapy. And it also is there's more and more evidence of its anti-inflammatory impact. So if in pyoderma, which is an inflammatory condition, as in a venous disease as well, but if it has this anti-inflammatory component, then it can really help to switch off inflammation very speedily. And there's not much medication that will do it as fast as that. So I think the power of compression therapy in reducing pain from inflammation is there as well. And we think it's just going to increase pain, but actually, if you do it well, it doesn't.
Excellent. Okay, well, thank you on behalf of all of the participants to Alison and Christine for your input. Really valuable as ever. We could go on forever, but unfortunately, we probably have to wind this webinar up now. But to the participants, thank you all very much for taking part in the webinar. I hope it's been useful for you, and especially for all of the questions that you've asked. Apologies again that we're unable to cover them all in this short presentation. Don't forget, you'll be able to access the video recording of this webinar on demand via the EWMA website in a few days. And we hope that you'll join us again for the next webinar on compression therapy. Get your questions in early. You can keep yourself updated and posted about the dates of the webinars coming via the EWMA website or the newsletter or on the social media platforms. So finally, just to say on behalf of all of us, myself, Christine and Alison, thank you again for participating and being with us. Stay safe, take care, and good night.
Good night.